I wanted to do better for myself. I wanted to demonstrate better for my family, for my children, and I wanted to do better for my patients. So that was really what I think set the stage for me to be open to the new information, the types of food that we eat being more important than the amount of food that we eat. We allowed a patient to get to the point that they need open heart surgery for what is really a totally preventable disease. Heart disease, in my mind today, is a preventable disease. And ultimately, I came to the realization that the patients that end up on my operating table, they are all failures. But it's not that the patient failed, it's that the medical system failed that patient.
He was a morbidly obese heart surgeon. Yes, you heard that right. Through high school, college, med school, and surgical training, he followed the U.S. dietary guidelines for both diet and exercise. Yet, nothing he did took the weight off. Each day in the operating theater, he would split open the chests of people just like himself. He was heading for the operating table and knew he had to find solutions that worked. In 2016, he finally found a way to lose 100 pounds and keep it off. Now, in addition to doing heart surgery, he helps people just like himself get healthy, lose the weight, and keep it off. Now, Dr. Phil Ovadia is a rebel MD who works against his own financial interest to keep people off his operating table. Dr. Ovadia, welcome and thank you for being here today.
Great to be here with you again, Rob. And I might need you to just follow me around and give that awesome introduction everywhere. It was a banger.
I will follow you all over the place because I'm, again, really excited to have met you, and we're learning so much all together in this space. Can you tell everyone a little bit about yourself that got you into this space? What was the trigger that says, Ovadia, change?
Yeah, it really was kind of what you talked about, right? That realization that I was headed for my own operating table. And it was also that desperation that, that the advice that I was taught to give, that I know you were taught to give, right? Seeing it not working for myself, for my patients. It just kind of came to that crisis point that I said, we have to be able to do better than this, right? I wanted to do better for myself. I wanted to demonstrate better for my family, for my children, and I wanted to do better for my patients. And so that was really what I think set the stage for me to be open to the new information. And you know how it is, right? When you open yourself up to the universe and you're open to hearing these new ideas, I think they find you, right? And for me, that event occurred while, ironically enough, I was at a Society of Thoracic Surgeons meeting, right? And I'm there expecting to do the usual thing, right? Learn how to do surgery better, learn about the new techniques. Coincidentally, or maybe not, one of the guest lecturers that was invited that year was Gary Taubes. And this was right when Gary had written The Case Against Sugar. And of course, prior to that, he had written Why We Get Fat and Good Calories, Bad Calories. Listening to Gary really opened my mind, right? And his concept of talking about the types of food that we eat being more important than the amount of food that we eat. This is what started my journey. And, I went on a low carb diet, eliminated sugar, like you said, was able to lose 100 pounds. And along the way, what I came to realize was that this is what my patients needed to know as well. This is what could help them. And ultimately, I came to the realization that the patients that end up on my operating table, they are all failures. But it's not that the patient failed, it's that the medical system failed that patient. that we allowed a patient to get to the point that they need open heart surgery for what is really a totally preventable disease.
Mm.
Heart disease, in my mind today, is a preventable disease. And when we don't give the patient the tools to prevent that disease, we fail that patient. And so that, is the change in my thinking now. And I know that we can do better by these patients. And that's what drives me today.
You've been doing this a long time, and cardiovascular disease is still the number one killer of all of us.
Mm-hmm.
And it's happening, it seems, younger and younger. And there seemed to be an up spike in the incidence of heart disease in the turn of the 1900s through the up to 2000, and still today it's very high. What did you learn from Gary Taubes and others that seemed to be the kicker that got us here?
Yeah, and great questions to be asking, and just to kind of drill in on this, right? I go back to when I was doing my surgical residency, and I was doing a training program in general surgery, and it came time to decide if you're going to subspecialize, and I decided, I wanted to go into heart surgery. I found it technically interesting. The physiology, behind it is fascinating. And so I decided I wanted to go into heart surgery. And my mentors at the time, my professors, told me that was a ridiculous idea because they said there's going to be nothing left for you to do in 20 years. This is the late 1990s, early 2000s. Statins are the most widely prescribed class of medication by that time. And the general consensus was we fixed heart disease, right? We figured out the problem. We have these medications, and a heart disease is going to be eliminated. And here we are 25 years later, right? Heart disease is still far and away the number one killer and worsening, despite that optimism about it. So, what I now have had my eyes open to, right, and what I've learned over the past decade or so while doing this approach, right, is that first and foremost, we must have something wrong about what we thought was causing heart disease. Because if it was cholesterol primarily or cholesterol only, as oftentimes the medical system today looks at it, then heart disease should be largely gone, right? Because we have these medications that effectively lower people's cholesterol. And we've been giving this dietary advice, right, to eat low-fat diets now for the past 40 plus years. And the evidence shows that people are largely following that advice, and people's cholesterol levels are lower than they've ever been. And yet heart disease is getting worse. So I think anyone logical, needs to looks at that and says, we must have something wrong about that underlying assumption about cholesterol. And that really is the big one, right? It leads you down other pathways, but that's the big one that we need to address.
Is there something about our modern diet? I mean, the recommended diet is plant-based, Mediterranean, 3 to 6 meals a day, lots of exercise, and that lifestyle that I know that I led. And I was never really heavy, but I was beginning to I had migraines since a kid, arthritis, psoriasis, bowel bleeding, kidney stones, ADHD as a kid. I couldn't read. My father had a quintuplet bypass in his early 70s, and he lived to 94 almost, and I'm sure he was had hypertension and all those things, and he was never really that active later on. And is it something that I need to be concerned about, or do you think this lifestyle we're talking about is something that can help me and others reduce their risk of it happening to us?
Yeah, so I think the answer is both. Yes, you have reason to be concerned, rightly, but the lifestyle that you've chosen and that we talk so much about, I do believe is the best way to minimize the chances of suffering that same fate. And I think it's something that we can't just assume that this lifestyle, this diet, low carb carnivore diets are going to fix the problem, but it does give us the best chance. And in conjunction with that, we should be actively kind of surveilling for heart disease, and we should be measuring how much heart disease do we actually have, right? And that's a key clarification or a key differentiator, right? It's not about measuring your cholesterol level and thinking that predicts your risk of heart disease. It's about measuring the actual heart disease. And we have ways to do that. And we should be utilizing those tools to do that, because that is really going to give us the information that we need to determine, okay, is this diet that I'm eating helping the problem or not? And, other components of my lifestyle, right? Are they helping or not? And that's something, again, that we don't do a great job of in medicine. We treat the disease when it occurs. When you have the heart attack, when you have the symptoms of heart disease, we start paying attention to it. And, in addition to the different paradigm around diet that I talk about, I also talk about this different paradigm about screening for heart disease, which is something we can actually effectively do these days.
And so family history on my side, obviously. Yep. And although my grandmother lived to 104, my parents lived to 94, and they were not particularly active. They ate a Mediterranean diet, and I thought I was very did a lot of exercise, ate a healthy diet. Yet when I look back to my father, and now I was gifted a CAC score back a year ago. I would have never gotten it myself. Is it a good start for people looking for their risk of heart disease?
Yeah, I think the CAC score is probably the best way to start figuring out your heart disease risk and your heart disease status. It's more than just risk. It's how much heart disease do you actually have today? And that's part of understanding what your risk is moving forward. And the CAC scan, so for people to set the basics, right? Coronary Artery Calcium scan. It is a CT scan. And so anyone that's had, CT scans are fairly ubiquitous in medicine these days, but they're simple tests to do. They're not invasive, right? You just lay down on the scanner and you get the scan done. The CAC scan in particular, you don't need to have an IV put in, so completely non-invasive. Literally takes about 3 to 5 minutes to do the scan. And in most locations here in the US, it's going to cost you $100 or less. So it's great that you got gifted that, right? And you were probably thinking, oh man, this is such an expensive test. Someone really went out of their way. Turns out that it's not that expensive a test, but it's such a valuable test. Like when I look at the value that we get from tests in medicine today, I think it is hard to find another test that beats the CAC in terms of being low cost, but such high value information that we get from it. And, it shows us heart disease. Now, it has its limitations, right? What we specifically see on that scan is whether or not there is calcified plaque in the arteries of your heart. Now, calcified plaque is only one type of plaque that occurs. So we're not getting the complete information, but it's a pretty good screening test, because if you don't have any calcified plaque, if your CAC score is 0, it is highly unlikely that you have significant disease today or are going to develop significant disease over the next few years. It's not a lifetime guarantee, but it at least is a pretty good guarantee in the next, let's say 5, maybe 10 years, that your risk of having a clinical event like a heart attack is pretty low. If it's not 0, right, it's then a sliding scale. And the higher the number, right, the more concern you should have about how much disease you have today and how likely you are to develop disease in the future. And so that then is going to lead you to maybe some additional testing, and also to be thinking about, what can I do to stop this from getting worse? And that's why I think the CAC scan is so powerful, because it gives you all that information, and it kind of starts to guide you towards, okay, now what can I do to stop this heart disease from getting worse?
Drum roll, please. So this was done about a year ago, and my CAC score was 682, placing me in the 70th percentile. And I don't know if the LAD was 488, left main coronary artery 57, circumflex coronary 5, right coronary artery 48, and the ramus branch 104. Total calcium score 468. And for some reason, it had where was that? The total coronary artery calcium score was 682. And then there's another one that says 468 on the second one. So I followed up with the CT angiogram.
Yep.
And this is the first time I've shared it with Dr. Ovadia. And let's see,
and maybe before you give that, Rob, let's just unpack the CAC score a little bit, right? So
please. Yep.
A score of 687, and they said you're in the 70th percentile, right? And those are the kind of two numbers that most people are going to pull out of their report. What is your total score? So it's called the Agatston score, after Dr. Agatston that developed this. And, it's basically, you can think of it as the volume of plaque that you have and the density of the plaque that you have. And you're kind of, multiplying those to get a score. And this score can be, again, you start with a 0. The highest score I've ever seen is about 7,000. So it gives you an idea about the range there. And, then they tell you your percentile. So what that means is, compared to people that are about your age and the same sex, right? So male and females have different kind of plaque levels typically. So in your case, right, it said you're the 70th percentile. So that means for men that are about your age, you have more plaque than 70% of them. 30% are going to have more plaque than you. And it tells you, okay, so you have a higher than average score on this, at least. And, you can use that to start to figure out, okay, what is my risk of disease over the next few years? And for people that are really interested in this, there's something called the MESA calculator, MESA. And you can go and you can put that in and go to the site, and you put in your calcium score, and you put in a few other factors like your age, your blood pressure, and your lipids. And it will tell you what your risk of having a heart attack is over the next 5 to 10 years. So that's how we start to use this score. Now, when you get scores that are above, some people say 200, some people say 400. But at some point you start to worry about, okay, do you actually have a blockage in your artery that is putting you at risk for a heart attack imminently, that is reducing the amount of blood flow that is going through that artery and threatening the muscle, right? That's what these arteries are supplying, is the actual muscle of the heart. So is that putting you at risk for a heart attack? And that's where we now need to get the further detail. And that's what the CT angiogram is. It's a more advanced type of scan. Logistically, the difference is they put an IV in your arm now, and they give you some dye through that IV. And by seeing that dye go through these arteries now, we can get more detailed pictures. We can see the calcified plaque, but we can also see the non-calcified plaque. And we can now start to measure how narrowed a blood vessel might be. So that's the additional information that we get from the CT angiogram. And now we can unveil what Dr. Rob's results are.
Well, interesting. So now, about 2 years ago, I had calcific tendonitis in my right shoulder. I couldn't move it.
Mm-hmm.
The X-ray the doc did, he said, you have more calcium deposits in your muscles than I've ever seen before, all over the place. I don't know if that's an important point to all of this anyway, but that was kind of an interesting thing that I found. Now, the next thing I did, and I don't have the results other than I did a treadmill echo test. What do we call that?
Yeah, stress test, we call it.
Echo stress test.
Right.
And he said, you're fine. I passed it with flying colors. All right. And then I said, well, is there anything else I can do? And that's where the CT angiogram came in as the next step. And the rereading of the total calcium score was now 724. The coronary arteries arise in normal position. There is right coronary artery dominance. The left main coronary artery is patent with no evidence of plaque or stenosis. The LAD artery is patent. There is diffuse calcified and non-calcified plaque proximally, which appears to narrow the lumen less than 50%. It gives off one small patent diagonal branch. The LCX, or the left circumflex artery, is patent. No diffuse calcified plaque in the mid circumflex, narrowing the lumen by about 50 to 75%. I don't know if that makes sense. There is, maybe it should say, there is diffuse calcified.
Yeah.
Is in the mid circumflex, narrowing the lumen by about 50 to 75%. It gives off one patent bifurcating obtuse marginal branch. There is dense calcified plaque at the bifurcation. The degree of calcification is such that any degree of luminal narrowing cannot be estimated. Cardiac valves, there's no thickening, calcification, or calcifications in the aortic or mitral valves, none. Pericardium contour is preserved with no effusion, thickening, or calcifications. So calcified plaque in all three coronary arteries with at least moderate luminal narrowing seen in the circumflex. And I think there was one other thing here. Let's see. I think there was mild aortic. Where did I see that? There was a little aortic, ascending aortic enlargement.
Okay.
Mild. And that was it. I have some other numbers. Would you like to hear some numbers? Or you want to go off on that first?
Yeah, so I think what that information is good information. And so what we're trying to determine here, like I said, there's two factors that come into play here. We have the physical structural narrowing of the blood vessel, right? So you picture the blood vessel as the pipe, and this plaque is building up, usually first at the edges of the pipe. And, over time, it starts to make that lumen that the blood is flowing through smaller and smaller.
Mm-hmm.
And so we have that physical measurement, right? In one blood vessel, they said it's maybe 25 to 50%. In one of the other blood vessels, they said it's 50 to 75%. And that's one piece of information that we need to know. Now, the other piece of information is, what is the physiologic consequence of that narrowing? In other words, again, the purpose of these blood vessels is to deliver oxygen to the muscle of the heart. And the heart muscle needs that oxygen to be able to do its work, right? Pump. At what point does the blood vessel become so narrowed that the muscle is not getting adequate oxygen? That's when we get into trouble. That's when we start having symptoms like angina, people talk about, chest pains, or that's when we have a heart attack if that oxygen supply is reduced enough. So we actually can combine the two pieces of information that you talked about. The CT angiogram tells us 50 to 75% narrowing, 25 to 50% narrowing in different areas. And the stress test that you mentioned having tells us what the stress test is actually measuring is there adequate blood flow getting to your muscle? So the stress test looked okay, meaning that you have adequate blood flow getting to the muscle. And the CT angiogram tells us, but there's plaque there, right? And some of it is a fair amount of plaque and is reducing that blood vessel by 50 to 75%. And so the information to take away from this is, okay, you're not at imminent risk of having a heart attack. You're getting good blood flow. And we now need to make sure that this plaque doesn't continue to accumulate. Because if that 50 to 75% blockage goes up to, let's say, a 80 to 90% blockage, that is likely, that may cause you trouble, and that may cause that reduction in oxygen delivery. And that's when, something needs to be done about it. But if you can stop it from getting worse, and, we'll talk about what things we might want to think about to stop it from getting worse, and it stays at this same level, there's no reason to think that you shouldn't be fine for the next, many, many years, and that you can follow your parents and your grandparents and live a nice, long, healthy life.
So now I do have some other tests here that I've done just kind of through the years. I've always had elevated cholesterol. And interesting, in general, my hemoglobin A1C has always been below 5.6, but at the time of this test, it was 5.8. I don't know if that's relevant, but my cholesterol level back in early January of last year was 405. The LDL cholesterol was 328. My glucose was 66. Prior glucose was 52. So I tend to have low glucose levels. And I've done insulin levels. I didn't have it, which are typically low. Let's see. I have a folic acid of 2.1, which is considered low. My homocysteine 14.7 in normal range. Lipoprotein A 14.8, iron normal, uric acid normal, vitamin B was 12, was mid-range, insulin was 2, ferritin 407, C-reactive protein was less than 1. It typically has been less than 1 on other draws. LDLP 1598, so that was in a borderline high range. HDLP was low at 23.8. And
you have
thyroid,
a small LDLP there?
I have a small LDLP was 153.
Okay, great.
And it's in the lower range of normal.
So we start to look at, right, again, we want to start to look at what are the factors that lead to plaque and lead to, ongoing plaque progression. And inflammation, insulin resistance, and having the poor quality cholesterol is the way that I think about it, right? It's not about the total amount of cholesterol per se. It's what is the quality of your cholesterol particles to determine, are they potentially problematic? So on the insulin, and insulin resistance front, right? You mentioned low glucose, low insulin level, and that, that's good. That's what you want. You want to live in a low glucose, low insulin environment for the majority of your life. And that is going to be powerful in preventing against heart disease. Now, the problem that comes up, right? And oftentimes I have people like yourself, right? They've been doing low carb carnivore diets for a while, and then they get their first scan, their first CAC scan, and the score isn't 0, right? And it's like, okay, when did this plaque accumulate? Did it accumulate recently when I've been doing low carb carnivore diets, or did it accumulate before I started that? And, for many people, right, they were insulin resistant, likely, and they had high glucoses, likely, but, they may not know that because they weren't really testing it back then, or maybe they were. But, it's more likely the plaque accumulated then than during, when you go low carb carnivore and the insulin resistance and the inflammation resolves. So, your part of the puzzle then becomes, okay, what's happening to your plaque over time now? And for someone like yourself, right, I would repeat typically a calcium score, or maybe even the CT angiogram, a year later, let's say, or 6 months later. And is there new plaque forming or not? That's what we now want to know, sort of moving forward. And if we've addressed the right factors, insulin resistance, inflammation, got in a good quality of our cholesterol, then that usually is going to translate to the plaque won't be progressing. And we just have to deal with the fact that, yeah, you accumulated plaque for the number of years that you weren't doing this stuff. And maybe there are other factors going on, right? You mentioned, a lot of calcium in your muscles. So maybe you're just prone to, you have a lot of extra calcium, and we got to figure out how to get that out of your body, or how to prevent that from worsening. Maybe there are non-dietary environmental factors, and I point people towards this often. And I think we're increasingly recognizing that, for instance, you can have a perfect diet, but if you're living in a mold infected home, and many of us are and don't know it, unfortunately, that might cause a problem. If you're getting exposed to heavy metals in your water, or perhaps, other environmental sources, that can cause trouble. And it may not show up in the traditional testing, but it can be an unrecognized problem. A fair number of people I deal with have periodontal disease that they may not know about, right? This could be something like an old root canal that's kind of chronically infected, and they don't know about it. This can also, again, the heavy metals from metal fillings, right, can contribute to heart disease. And so it's a bit of a detective work, right? You gotta keep digging deeper until you figure out what are some of these factors that might be driving the ongoing heart disease, if it's continuing to get worse, right? Someone like yourself now, who, okay, we know what you have. We don't know when that occurred. We know that your other numbers are now looking pretty good, right? You don't have insulin resistance. You don't have inflammation. The quality of your cholesterol particles look good. And so, I would probably say we could sit tight and we could get another scan in 6 months to a year, and we can see, is there more plaque accumulating or not? And if there isn't more plaque accumulating, then we should be pretty good. If there is, like I said, we got to keep kind of, digging another layer deeper and saying, okay, is there something else going on that we haven't identified that's driving this plaque formation?
Where does a angiogram come into play in someone without cardiovascular symptoms? I'm pretty active. And where does that give us a better answer to all of this?
Yeah, so, it's interesting. The CT angiograms, compared to what you're talking about, an invasive angiogram, a cardiac catheterization, where they actually feed a catheter up into the heart. They're fairly equivalent these days, right? The CT angiogram gives us a pretty good picture. And so in my mind, right, the angiogram now gets reserved for people who we think are going to benefit from having a stent placed, or, we're potentially thinking might need bypass surgery, might need something done about their blockage. And, that comes down to either you're having symptoms, or you have demonstration of reduced oxygen to the muscle, right? A positive stress test, for instance. Those are the scenarios where, okay, we need to now go ahead with a catheterization with an invasive angiogram because we're thinking we might need to put a stent to open up a blockage, or we're getting the real fine detail that we need to plan doing bypass surgery. But in someone like yourself that we have a negative stress test, the CT angiogram doesn't show any critical blockages, meaning above 80% or so. And so, and you're doing high level activities on a daily basis without having symptoms. All of that says we don't need a catheterization at this point.
But with these numbers and family history, repeating the CT angiogram 6 months to a year would be reasonable, just to kind of see whether or not it's progressing or it's stable or getting better.
Yeah. Or getting better. Yep.
Do you see it getting better?
Yeah, I do see people that reduce the amount of plaque that they have. And we measure this with CAC scoring, or even with CT angiography, we can measure reduced amount of plaque. So, yes, you do want to keep an eye on this, right? It is something to, we can't just say, okay, you're okay today, you're going to stay okay for the next 10 years, right? We want to be actively sort of looking out and making sure that the problem isn't getting worse.
If you were noticing some narrowing more than it was, yet cardiovascular, I'm fine, you would just make the changes, lifestyle, or look at dental work, or look at our environment and things like that. You brought something up about mold, but I'm wondering, like H. pylori turns out, gastric ulcers tends to be a disease of an infection. And I'm wondering if cardiovascular disease may be related to, as you mentioned, mold or other chronic infections, like you mentioned in the mouth and the gut and other areas that may seed the glycocalyx, or the sugar layer of the vessels, and may cause a lot of this chronic and acute inflammatory changes.
Yeah, so chronic infections of all sorts have been associated with cardiovascular disease. Even acute infections. It's interesting. People that have the flu are at increased risk of having a heart attack, right, during that few weeks after they have the flu. And then we know that chronic infections, things like mold, chronic Lyme infections, chronic periodontal infections, these are all associated with increased risk of heart disease over the longer term. So there's definitely a link, right? And there's been a debate for many years within the, heart disease community, do those pathogens directly, cause trouble in the blood vessels? Do those pathogens set up a state in the body that things like blood clotting are more, likely to occur? And blood clotting plays a role in these plaque developings and in having heart attacks. Or is it, again, the inflammatory response that is set off in the body by infections, that those inflammatory factors, right, they're going to circulate through the heart and through the blood vessels and could be causing damage to the blood vessels in that way. And the answer is probably all of the above, right? All of these different pathways probably contribute some to the heart disease that results from these chronic inflammatory and infectious states.
Apparently, people like Seventh-day Adventists that are mostly plant-based tend to have great longevity. Now, I haven't really seen the unbiased studies personally. Do you think that a carnivore diet is going to significantly reduce someone's risk, or we just don't know that yet?
So The honest truth is we don't have the hard data on this that we need. However, I would say there's lots of reasons to think that it would. And the reason I say that is, again, we know the two primary drivers of heart disease: inflammation and insulin resistance. We know that a carnivore diet improves both of those things pretty reliably. You and I have now seen it with, a countless number of patients, right? Inflammation, insulin resistance, these get better on a carnivore diet. So that's what makes me believe that it's going to help with heart disease. Now, I have a very active medical practice focused on this issue, right? People that are doing low carb carnivore diets and heart disease, and we're tracking them and we're doing the scans. And so far, right? And again, I admit, I haven't done a full audit and publication of my practice, but the general trend that I'm seeing is that heart disease stops getting worse and in some cases gets better in people that are following these diets. My caution, like I said earlier, is I don't want to just assume that. I want to keep proving it to myself and to the patients. And that's why we're very aggressive, I would say, about doing the lab work and doing the scans and making sure that things are actually, not getting worse or getting better. And so that's the approach that I take to this. And again, I think that's contrasted against the standard cardiology approach, which is take your statin and we'll wait and see if you have a heart attack. And that's a very passive approach. And quite frankly, I think it's a very disempowering approach. And our approach is empowering the patient. The patient is taking an active role. The patient is doing the things that are stopping them from getting worsening disease. And it is very empowering. And I think that's, one of the reasons that people respond so well to it.
You and we met in Tampa, and you said something about small particles of lipoproteins, and I think it was the particle A, and you could comment about that. And it kind of dawned on me, really, you're measuring inflammatory particles. And by doing that, we're kind of measuring, do you have inflammation going on in your body? And are these cholesterol measurements accurate enough to define inflammation, or are there other things we should be looking at?
Yeah. So so as I alluded to earlier, right, and I even asked you about your numbers, right? The quality of the cholesterol is what's important, not necessarily the quantity of the cholesterol. And that's what looking at these advanced metrics and the particle sizes starts to get us towards. We know, so the misconception that happens, right, that has been spread throughout medicine is LDL cholesterol particles are bad particles. And it turns out that's only partially true. Some LDL particles are bad particles, are what we call atherogenic, meaning that they actually are the ones that are in the plaques that form. But some LDL particles are not atherogenic. And this isn't anything that's debated, right? This is well established. And you can talk to any of the leading lipidologists, right, about this, and they acknowledge it. They just sort of don't put it into practice, right? They say it's easier to just reduce all LDL than to really try and focus on the small LDL particles, the ones that are actually atherogenic. And there are a number of reasons why that might be, and we could get into some of that. But ultimately, small LDL are the atherogenic particles. And I don't care if you have a lot of large LDL around, and you shouldn't care. And maybe it's something you should actually want to do, because large LDL particles play many beneficial roles in our body. And so that's where that nuance comes into play, right? That looking at LDL, or, today the more modern lipidologists will say, well, look at ApoB, right? Which is another way of looking at this. But ApoB still has the same problem. It's measuring both the large LDL and the small LDL. And unless you get that advanced lipid panel, you don't know which one you're dealing with. There are clues, right? Because people that have inflammation, people that have insulin resistance, this is what causes you to have more of the small atherogenic LDL particles. And generally, people that don't have those things, they have less of the small atherogenic particles. And that's why we don't necessarily need to be worried about their cholesterol, their total cholesterol levels, right? And someone like yourself, again, you now have those numbers and you show that, about 10% of your particles were small particles. That's a low percentage, right? And so that's a good target, right? A good goal for us is keep our small particles low. That's what we're really after. And that just gets lost in the general sort of approach of just lower all LDL.
And I kind of imagine, so lipoproteins are made in the liver in general, and then they're sort of delivering minerals, vitamins, and fat and proteins and sugars to all cells of the body. Is kind of something happening to them along the journey that's creating these smaller particles that we're calling sort of almost inflammatory markers?
Yeah, and the way to think about it is basically, the particles themselves are damaged, and that because of that damage, they're not being recycled properly. All of these LDL particles, right, they get recycled. And what happens with the small, dense particles is they don't get recycled properly. They kind of hang around longer in the bloodstream, and that's when they can start to cause the trouble. And specifically, if those small, dense particles, they get into that blood vessel wall, right? They get through that glycocalyx that has been damaged, and, they get into that blood vessel wall. And because they are damaged particles, they then set off an inflammatory reaction within the blood vessel wall. And that's what really ends up leading to this plaque formation ultimately.
And one of the problems seems to be that we blamed fat for the cause of disease and not recognizing that plant sugars were probably the biggest factor, and maybe even too much lean meat and not enough fat. I'm just wondering, in our low carb world, why don't we call it a high fat world?
Yeah, it's a very good question, right? And people focus on the carbohydrates as the problem, and there's reason to do that. Although I don't know that the carbohydrates themselves are enough to cause the problem. We look at things like vegetable and seed oils, for instance, and what role do they play in all of this? But we do know that once you are insulin resistant, right? Once something has happened and you've got into this insulin resistant state, your body can no longer process the carbohydrates. So the carbohydrates are the problem. You withdraw the carbohydrates and you give your body a chance to recover. And oftentimes it will recover from this insulin resistance. So, that sort of became the focus. But you're right. I actually choose, I think the better way to think about the dietary approach, right, is not what you're taking away. It's what you want to feed your body. What gives your body the best, nutrients and everything that it needs. And that turns out to be animal protein and the fat that comes with it. These are the ways that we can best supply our body with the nutrients that it needs.
I followed Andres Ehrenfeld, diet doctor years ago, and he did LCHF, low carb, high fat. And I've never seen butter mold. I get butter in my refrigerator for like almost a year, never molds. And I'm just wondering, and if we focused on adding more fat, might that be the simple answer, that it's not so much the carbs, but it's the ratio of the amount of fat to the plant material?
Yeah, I mean, and the problem, the only, I guess, problem I see with that sort of approach, right, is that, people have to recognize the right types of fat, right? And this is something else that we've gotten very wrong in our messaging, because we've been told, okay, the plant fats are the better fats, right? Forget about the plant sugars for a minute. The plant fats, these vegetable and seed oils are supposed to be the better fats for us to eat. But again, the evidence shows us otherwise, right? And all levels of evidence show us that these plant fats are not beneficial to us. Going back to the particle sizes, right? One of the things that will reliably make your particles smaller is consuming, the polyunsaturated fats, the vegetable and seed oils. That becomes a problem when you're trying to rationalize that these plant fats are good for your health. They're clearly not. They're not good for your heart or any other part of your health. And so, yeah, I am all in favor of animal fats, animal proteins. This is what we thrive on. This is what our body was designed to exist on.
Yeah, I always say there's no such thing as plant fats. It's plant oils, which are all industrial, because when we went hunting 50,000 years ago, you would never be like, well, let's get some of the fat off the plant. It just
Yes.
doesn't exist, does it? It does.
Very good point.
Tell us a little bit about stress and how that affects our lives, our lifestyle, and inflammation, and ultimately heart disease.
Yeah, stress is definitely plays a role in all of this, right? And again, it plays a role through a number of different pathways and mechanisms. Now stress is always the hardest one to talk about because we don't have a great way of measuring it, honestly, right? We don't have a way of quantifying it. And it is sort of a subjective thing. But what happens in our body in response to stress is very objective, right? We can measure all the hormones that change, the cortisol that gets made, the blood sugar that goes up. And because of that blood sugar going up, the insulin then has to go up and can get us into that cycle that can ultimately lead to insulin resistance and inflammation. Stress is a very real part of this, and it is a factor that people need to pay attention to as part of their, strategy for dealing with, for preventing heart disease and, of course, the other chronic diseases that go along with it.
Yes, it's one of the best things I think we can do is work on things like meditation and prayer and connection. And I think that's one of the amazing things I've learned about this carnivore community. There's a lot of great connections we're all building. And I highly recommend those listening is join a group out there, whether it's keto, carnivore, or a yoga class or a music class or something. But the beauty of the carnivore community is we're inviting of everyone, whether you're vegan, vegetarian, Mediterranean. We just want to sort of share ideas and help people on this journey. And I know your community is growing, and join these communities because people care about this. Exercise, moving.
Yeah.
I work in an office, although I stand up desk these days, but for years, we're not exercising, we're not moving. What's your thoughts on how people can improve their cardiovascular health and reduce their risk factors?
Yeah, I mean, it really is just about get moving, right? And whatever you're doing, just try and do a little bit more. It doesn't need to be hours at the gym. And I think sometimes people get intimidated, right? Because they're like, well, I don't have those hours to spend at the gym, so I shouldn't bother doing anything. It's amazing when you look at the scientific literature around exercise, right? The biggest difference is that 0 to 1. When you go from doing nothing to doing a little, it makes a major impact. So stand-up desk, like you mentioned, just take that 10-minute break after you have lunch at work, right? and go take a lap around your building inside, or if the weather's great, even better, do it outside. And it doesn't have to be complicated. You don't have to break a sweat. You just have to get, some activity into your day. And you do that more and more. Yeah. And have simple thing like a little weight next to your desk. And you do that, a couple of times throughout the day, and it's going to have major impact. So I always encourage people to just get more active, right? You don't worry about, going and spending an hour in the gym. Just get more active.
And I know a lot of people have a walking pad at their office, their home, or a stationary bike to just get moving. And I actually love to watch Phil Ovadia while I'm on my treadmill, and many others. It just it's a good time for me to sort of like catch up with what's going on, but I'm moving and not sitting around and laying around on that couch, which could be very comfortable and hard to get up and off of it. Because if you don't get off the couch, you're going to get on Dr. Ovadia's operating table. So you got to be careful, right?
Exactly.
Let's see. So you already commented it's possible to reverse heart disease, and that's something that we all need to recognize. There is a way to improve our health and wellness in ways maybe we haven't learned before. What about patient comes to you in the office? And I don't know, I always sense that a lot of us, you go to the doctor and they go over your problems, but they don't go over your successes. Is that something we in medicine maybe could focus on people's successes a little bit better?
Oh yeah, definitely so. And in my practice, and this is a great thing for us to kind of wrap up on, right? One of the things we do is celebrate those successes, right? We're all about the successes. And again, it's giving the power back to the patient. It's empowering that patient to make their own successes. And that's one of the things that we focus so much, in my practice now on, is how can we empower the patients, right? And them recognizing their own successes is a great part of it, right? And then they start to that has positive effects. You mentioned the community earlier. And again, I think that's one of the things that's so wonderful about this carnivore community is we do, celebrate what everyone is accomplishing around us. And it's just such a positive environment. Like you mentioned, we were at a meetup event this past weekend, and it was just an amazing environment, seeing all these people that have had these successes. And some of them are earlier in the journey and some of them are later in the journey. And we can all be there to kind of support each other, promote each other, and celebrate each other. And I think that is that also leads to better health, just being in that positive environment.
And I know, like yourself and myself, we're seeing so much improvement in people's health by being in this community where one by one in an office all day, you're just not seeing the greatness of this story. Dr. Ovadia, where can people find you? And please mention the name of your book so everyone knows that.
Yeah, definitely. So the book is called Stay Off My Operating Table, widely available, all the usual places. And then you can find me everywhere at iFixHearts. You can go to ifixhearts.com, or you can go to any of the social medias at iFixHearts, and you can connect with me and my team. My telemedicine practice, we see patients across the country and even internationally, and always happy to connect with people who might want to work with us.
Well, I appreciate Dr. Ovadia's time, and you can find him. We'll put links in the talk, and I might even throw some of my tests up there so people could look at them and compare them. And I'm going to get my repeat tests, and we'll do this conversation again very soon. Thank you, Dr. Ovadia.
Awesome. Great seeing you, Rob.
God bless all.